Welcome to the deep dive. Today we're really zeroing in on sickle cell crises. It's definitely a key area for medical professionals, especially if you're prepping for exams like the MSRA.
Absolutely. Our mission here is to take the revision notes you have on sickle cell crises and just, give you a really clear high-yield summary, everything you need for good recall. Think of it as the fast track.
Exactly. And we'll be using some memory tricks, mnemonics, that sort of thing to help it all sink in. So let's dive right in. What exactly is a sickle cell crisis?
Okay, so simply put, it's when someone with sickle cell disease gets these really severe episodes of pain or other complications.
Right.
And the basic problem, the underlying cause, is that their red blood cells, which should be round, they sort of collapse into a sickle shape.
And those sickle shapes cause blockages.
Precisely. They get stuck in blood vessels, obstruct the flow.
Leading to what exactly?
Well, that blockage means tissues don't get enough oxygen. That's tissue ischemia.
Yeah.
And that lack of oxygen, well, it causes damage, painful damage.
Okay. Your notes mention 5 main types of crisis. Let's maybe break those down.
Sounds good. So the first one is thrombotic crisis. You'll also hear it called painful crisis or vaso-occlusive crisis.
Vaso-occlusive, that name kind of gives it away, doesn't it?
It really does. Vasal vessel, occlusive blocked. The blood vessels are literally getting blocked up.
And what usually sets these off? What are the triggers?
Often things like an infection, maybe not drinking enough fluids, dehydration, or getting low on oxygen. Importantly, diagnosing this type is usually based on how the patient presents their symptoms. It's a clinical diagnosis.
So tests are more for ruling other things out.
Mostly, yes. Ruling out other causes for the pain.
Where do these blockages tend to hit hardest?
They can cause infarcts, basically tissue death, because the blood supply is cut off. We see it in bones quite often, leading to something called a vascular necrosis. Also the lungs, the spleen, even the brain. It's like a traffic jam stopping supplies getting through.
Right, I see. Okay, so that's thrombotic or vaso-occlusive. What's the second type?
Number 2 is sequestration crisis. Now here, the sickling is happening mainly within certain organs. The spleen is the classic one, but sometimes the lungs too.
And what does that do?
It means a whole lot of blood gets trapped, kind of pooled in that organ, which, as you can imagine, makes the anemia much worse, quite suddenly.
Is there a specific blood test finding that points towards sequestration?
Yeah, you'll often see a rise in the reticulocyte count. That's the bone marrow trying to churn out more red cells to make up for the ones trapped in the spleen or lungs.
Okay, that makes sense.
Yeah.
The marrow's trying to compensate. Next is acute chest syndrome. Sounds serious.
It is, yeah. It's definitely one of the more dangerous ones. Again, it's vaso-occlusion, but this time it's happening specifically in the tiny blood vessels within the lungs.
So blocking blood flow in the lungs.
Exactly. And that blockage can lead to infarction damage or death of the lung tissue itself.
And I suppose the symptoms would reflect that directly.
Absolutely. You're looking for things like dyspnea, shortness of breath, chest pain. You might see pulmonary infiltrates on a chest x-ray, meaning areas of inflammation or fluid, and definitely low oxygen levels in the blood, low PO2.
And managing that sounds like it would need a few different approaches.
It does, yeah. It's about hitting it from multiple angles. Strong pain relief, giving oxygen, often antibiotics because infection can be a trigger or complication, and sometimes blood transfusions are needed to boost oxygen delivery.
Right. Okay, moving on. Aplastic crises. What causes these?
Aplastic crises are usually triggered by a specific virus, parvovirus B19, actually.
Ah, the slap cheek virus.
That's the one. In people with sickle cell, it can cause a temporary shutdown of red blood cell production.
So what would you see in the blood results?
You'd see a really sudden, quite dramatic drop in hemoglobin, and crucially, a low reticulocyte count. The factory is temporarily closed, basically.
Got it. And the last type listed is hemolytic crises.
Yeah, hemolytic. These are rarer, apparently. It's where there's a sudden increase in the rate that red blood cells are being destroyed, hemolysis. And again, that causes the hemoglobin level to drop.
So 5 types, all happening in people with sickle cell disease. Let's just recap the fundamental reason why this happens, the etiology.
Okay, so yeah, crises happen in sickle cell disease, and especially in the most common and severe form, which is sickle cell anemia. The absolute root cause is an abnormal type of hemoglobin called hemoglobin S.
HbS.
Right, HbS. And under certain conditions, stress conditions for the body, this HbS, makes the red blood cells warp into that rigid sickle shape instead of being nice and flexible.
And those certain conditions are the triggers we mentioned earlier.
Exactly. The big ones are things like dehydration, getting an infection, being exposed to really hot or cold temperatures, physical or emotional stress, and hypoxia, low oxygen.
Is there a way to remember those triggers easily?
Well, You could try something like DHH, perhaps.
Hmm?
Dehydration, infection, temperature extremes, stress, hypoxia might help it stick.
DIT stage. Okay, useful. So who's most likely to get these crises? What are the risk factors?
Well, the biggest risk factor is obviously having sickle cell disease itself, particularly sickle cell anemia. But beyond that, things that increase the risk include having had crises before, maybe not managing the condition optimally day to day, and then exposure to those triggers we just listed, the DITH ones. Plus, things like pregnancy can sometimes be a trigger too.
Okay. Let's dig just a bit deeper into the mechanics, the pathophysiology. How does it actually happen at the cellular level?
Right. So we know it's about the blood vessels getting blocked by these sickle cells. It starts with that hemoglobin S. When oxygen is low, or the person's dehydrated, these HVS molecules inside the red cell start sticking together. They form these long, rigid rods or polymers.
Polymerization. And that's what physically changes the cell shape.
That's exactly it. The cell loses its flexibility, becomes stiff, takes on that sickle shape. And crucially, these sickled cells are also stickier. They tend to adhere to the lining of the blood vessels, the endothelium.
So they're misshapen and sticky. A bad combination.
A very bad combination for blood flow. That rigidity and stickiness is what leads to vaso-occlusion, the actual blockage.
And the downstream effects of that blockage are what we see as the crisis.
Precisely. No blood flow or reduced blood flow means no oxygen gets to the tissue's ischemia. And that ischemia triggers inflammation and causes that awful severe pain that characterizes many crises.
Now, thinking clinically, if someone comes in with severe pain, how do you know it's a sickle crisis versus something else? What are the main differential diagnoses?
That's a really important practical point.
Mm.
Severe pain can be caused by lots of things. You have to consider bone fractures, maybe acute abdominal problems like appendicitis or gallstones, kidney stones causing renal colic, or even vasculitis, inflammation of the blood vessels themselves.
So how do you tell them apart?
It's usually a combination of things. How the patient presents the history, the exact symptoms, what you find on examination. Obviously, if you know they have sickle cell disease, that points you strongly in one direction. And then you use tests, blood tests, maybe imaging, to confirm the crisis or, importantly, to rule out those other possibilities.
Okay. What about how common this is, say, here in the UK? What's the epidemiology look like?
Well, sickle cell disease mainly affects people whose ancestry traces back to regions like Africa, the Caribbean, the Middle East, and South Asia. Here in the UK, the estimate is around 15,000 people living with the condition.
And how often do they experience crises?
That's harder to pin down with exact numbers. The prevalence isn't perfectly established. But we know crises are, unfortunately, a common part of living with sickle cell disease, especially for those with sickle cell anemia.
Right. So let's picture a patient arriving. What are the key clinical features you'd be looking for? How does it actually present?
Okay, for the most common type, the vaso-occlusive crisis, or VOC, the absolute hallmark is severe episodic pain. It can be pretty much anywhere, but really common spots are bones, long bones, back joints, the abdomen, or the chest.
And for acute chest syndrome, the red flags.
Yeah, as we said, definitely look for chest pain, difficulty breathing, shortness of breath, maybe a cough. Respiratory symptoms are key.
And splenic sequestration? What would make you think of that?
The big clues there are a suddenly enlarged spleen. You might feel it when examining the abdomen causing abdominal pain and signs of rapidly worsening anemia on blood tests.
And other types of crises or complications?
They generally present with symptoms related to whichever organ is being affected by the vaso-occlusion. So stroke would have neurological signs, priapism is obvious, and so on. The symptoms point you to the affected area.
When you suspect a crisis, what investigations do you typically reach for?
Well, it always starts with the basics, doesn't it? A good, thorough history and a physical examination. And really focusing on assessing how severe the pain is for that individual.
And lab tests, what bloods are most helpful?
The full blood count, the CBC, is essential. You're looking at the hemoglobin level to gauge the anemia, the white cell count for signs of inflammation or infection, and the reticulocyte count, as we discussed, which can help differentiate types of crises.
Does imaging have a role?
Yes, definitely. Things like X-rays or sometimes ultrasound can be useful. A chest X-ray is vital if you suspect acute chest syndrome. Imaging can also help rule out other causes of pain, like a fracture or an abdominal issue.
Okay, so you've investigated, you suspect a crisis. How are these managed in the UK? What are the main aims?
The key goals are: 1, get the pain under control quickly and effectively. 2, treat any specific complications that are happening. And 3, try to identify and deal with any trigger that might have set it off.
How do you tackle the pain?
It's usually a stepwise approach with analgesics, starting with things like paracetamol and NSAIDs like ibuprofen if appropriate, but very often needing stronger painkillers, including opioids, for severe pain. Patient-controlled analgesia, PCA, is sometimes used.
And given dehydration is a trigger, fluids must be important.
Absolutely vital. Good hydration, either encouraging oral fluids or giving intravenous fluids, is a cornerstone of management. And of course, if there's an infection, you treat that with antibiotics. Oxygen therapy if their saturation levels are low.
You mentioned transfusions earlier. When do they come into play during a crisis?
Blood transfusions are usually reserved for more severe situations. So definite indications include acute chest syndrome, very severe anemia, sometimes during pregnancy, or if the person needs surgery. It can help improve oxygen delivery and reduce the percentage of sickle cells.
What about those disease-modifying drugs like hydroxyurea? Do they help in the acute crisis?
Good question. So hydroxyurea, or hydroxycarbamide as it's also known, is really important for preventing crises if someone gets them frequently. It works over the longer term to reduce how often and how severe the crises are. It doesn't really have a role in stopping a crisis that's already happening.
So it sounds like managing a crisis well needs a really coordinated effort.
It really does. It's not just about the immediate medical treatment. It's also about educating the patient about their condition, helping them spot early warning signs, managing triggers, and providing psychological support too. Living with sickle cell can be really tough.
What's the outlook generally for people who experience these crises? What's the prognosis?
It does vary quite a bit,
Hmm.
It really depends on how frequent the crises are, how severe they tend to be, whether complications develop, and how well they respond to the ongoing management and preventative treatments.
But good management can make a real difference.
Oh, definitely. With good, consistent medical care, preventing crises where possible, managing them effectively when they happen, many people can live full lives. But we have to be realistic. Recurrent crises, especially severe ones, can lead to chronic organ damage over time. And that does impact the long-term outlook.
So catching things early, managing consistently, that's key.
Absolutely. Early diagnosis of the disease itself, prompt treatment of every crisis, regular checkups, good preventative care, all of that is crucial for improving quality of life and potentially life expectancy.
And finally, let's just touch on the potential complications again. What are the main long-term risks?
Yeah, the complications can be serious. We're talking things like chronic, persistent pain, even outside of crises, damage to organs like the kidneys, lungs, heart, liver, due to that repeated lack of oxygen. There's the risk of recurrent acute chest syndrome, problems with the spleen leading to infection risk. Stroke is a major concern, priapism in males, leg ulcers, gallstones, and generally a higher risk of infections.
And these really add up over time.
They do. Frequent or severe crises definitely contribute to these long-term problems and can, unfortunately, shorten lifespan. It underlines why prevention and optimal management are so critical.
Okay, so let's try and pull that all together. We've dived deep into sickle cell crises. These painful, complex episodes driven by sickle-shaped red cells blocking blood flow. We've covered the main types: thrombotic, sequestration, acute chest, aplastic, hemolytic. We've looked at the root cause, hemoglobin S, and those key triggers summarized by DITSH.
Right. And we've touched on the risk factors, the nitty-gritty of pathophysiology, polymerization, adhesion, vaso-occlusion. We talked about telling it apart from other conditions, how common it is, how patients present, the investigations needed, and the really important multi-pronged management approach.
Plus the prognosis, which depends so much on good care and those significant potential complications. Hopefully thinking about it in these sections helps make it clearer.
And remembering that link between the underlying problem, the triggers, the symptoms, and the treatment really helps lock it in, I find.
Okay, quick quiz question for you listening. A young adult with known sickle cell anemia comes to A&E with sudden onset severe chest pain, shortness of breath, and a fever. Chest x-ray shows a new infiltrate in the right lower lobe. What's the most likely diagnosis?
Given that combination, chest pain, dyspnea, fever, new infiltrate on x-ray in someone with sickle cell, you'd have to be highly suspicious of acute chest syndrome.
Exactly. And those triggers, again, DITS.
Dehydration, infection, temperature extremes, stress, hypoxia. Keep those in mind.
So as you revise for the MSRA or just want to solidify your clinical knowledge, hopefully this deep dive has given you a really practical, memorable framework for understanding sickle cell crises. We've hit the definitions, the types, the causes, management, all the key bits.
And maybe something to think about going forward. Considering the genetic basis and the environmental triggers, How might advances in things like personalized medicine change how we predict, prevent, or even treat these crises in the future?
That's a great thought to leave you with. For more fantastic revision resources, definitely check out pathemsera.com and also freemsera.com. Thanks for tuning in to this deep dive on sickle cell crises.